So today we're going to talk about three viruses, the three blood-borne viruses, the BBVs. Those viruses are hepatitis B virus, hepatitis C virus, and HIV. Hepatitis B and hepatitis C are viruses that infect the liver. They cause liver damage, which can lead to cirrhosis and can lead to cancer. HIV is also a virus that's carried through the blood, and this is a virus that infects the immune system. Hepatitis B differs from hepatitis C because for hepatitis B we can block it with a vaccine. Hepatitis C is the one that we can cure. So if you walk away from this talk knowing nothing else, you will remember Hep B, the B is block it with a vaccine, and C is we can cure it with tablets. So first of all, let's think about HIV. So HIV is a virus that infects a group of cells called CD4 lymphocytes. These are the core of your immune system. They control all of your immune response. So when you become infected, HIV starts to deplete the numbers of those cells that you have. HIV is most commonly caught through unprotected sex. Now note that I didn't say gay sex, I didn't say anal sex, I said unprotected sex. In fact, worldwide, the most common person to be infected with HIV is a heterosexual woman. So you might be familiar with the concept of AIDS. So AIDS represents the final stage of HIV infection, when your immune system is completely depleted. HIV is transmitted, can be transmitted through unprotected sex. It can be transmitted through sharing needles. It can be transmitted from mother to baby. Currently, there are no cures for HIV, but what we can do is we can treat with tablets and prevent progression of the disease. So prevent AIDS from happening, and also prevent transmission from happening by maintaining patients on treatment. So let's think for a moment about what's actually happening when somebody gets infected with HIV. So a patient gets infected, so a small number of lymphocytes get infected with the virus. This might be in the genital tract, for example. Other immune cells will come in, and those immune cells then become infected, and you end up with this exponential rise in the amount of virus that's there, and at the same time you see this death of large numbers of these key immune cells. Then you reach pretty much a steady state, but over time the numbers of those key immune cells will decline. As the immune cells decline, the amount of virus in that patient will rise. Once the immune cells drop below somewhere between 200 and 300, you start to notice that these patients have what we refer to as constitutional symptoms. So what we would typically see are patients who have infections that they might normally have, but they're taking a lot longer to clear. So it used to be the case that one of the diagnostic criteria for AIDS was to have diarrhea for 6 months. But typically at this stage what we're seeing are coughs and colds that don't clear for weeks, for months. But we're getting towards a period where the immune system is close to collapse. There is a point at which the immune system can no longer control the viral infection of HIV. And at this point the viral loads start to rise dramatically, but also you become exposed to infections that we refer to as opportunistic infections. So quite often these might be fungal infections, for example, that we wouldn't normally expect people to suffer with, and infections in places that we don't normally see. So top left is a brain scan from a patient with a condition called progressive multifocal leukoencephalopathy. Try saying that when you're sober. So this particular picture allows me to tell a story that I will take to my grave. So in the 1990s, working at UCH, I worked alongside a guy who studied JC virus, and JC virus is the virus that causes this condition. Now, patients that had this disease, so in typical encephalopathy, the confusion, but critically, those patients were often dead in the very near future. So we were trying to understand this virus. We were trying to find out more information, and what Chris needed to do was to actually get samples of virus. And there was a patient in the hospital that had volunteered to have pieces of his brain taken. So you can imagine, as a laboratory scientist, this guy who worked behind me would get these tubes with maybe 1 millimetre cube of brain tissue from this guy. And he would amplify up the virus and he would study it. After several weeks of the tiny tubes, eventually a box arrived, boom, on the desk. Inside the box was the brain. This guy had died. And what I remember, absolutely crystal clear to this day, was a toadstool that was growing out of this guy's brain. So immune system's completely collapsed. This person is effectively an open petri dish. Picture top right is of pneumocystis carnii, pneumonia. So you have a florid infiltrate. The immune cells are coming into the lungs are filling up with fluid. This patient is effectively drowning in their own fluids. Kaposi sarcoma, bottom left, another condition that we were studying at the same time. So Kaposi sarcoma was this rare cancer of blood vessels under the skin that happened in Eastern Mediterranean men. Really, really rare cancer. You went to dusty tomes of nature to try and find any references to it. And what we were seeing was that this was popping up commonly amongst gay men in London, and that these men often didn't live much longer. So another end-stage complication. It was because normally their immune system would clear this, but because their immune system is so badly damaged, then they were dying of these strange cancers. In this picture here, we have a picture of thrush, really, really, really florid thrush. Candida albicans infection throughout the mouth, really, really nasty. So at that time, we had pretty much no treatment. The average time from diagnosis to death was a year, and this is what death looked like. Really, really frightening. So if you're going to go back to work and be worried about having a conversation about somebody's sex life, kind of shy away from it. I want you to think about the people that I'm describing here, right? Because if we don't diagnose people and we don't get people treated, this is what happens. And current guidelines for HIV are that as soon as we identify somebody as HIV positive, they are referred and they will be treated. So what does treatment look like? Now, I'm not asking you to understand this whole picture. For 7 years of my life working on HIV at Pfizer, this was my life. What we were trying to do was identify points of intervention that would allow us to block the virus. And what we'd learned in the 1990s is if we had one, it might work quite well in tissue culture. It might stop a virus from growing in our culture system. But actually in the real world, the patient, their viral load would drop, but it would just come back again, and it didn't extend their life. What needs to happen is you need to stop this life cycle at multiple points. So if the virus finds its way around one of them, then we've got other places that we can block it. So the thing to take from this picture is that modern HIV treatment involves multiple drugs, preferably combined into a single tablet that somebody can take in the morning, but multiple drugs, multiple treatments. And what we don't want to see happen is patients playing pick and mix with their treatments. We don't want to see patients picking and choosing which of the tablets they want to take, because what happens then is they'll quite often lose that particular target to resistance. The other way of developing resistance is if there are interruptions to treatment. And going to prison is often an opportunity for a treatment interruption to happen. So what I want you to do, when you go away, I want you to think about, find out how you get the HIV meds to the guy or woman who comes into your prison, who says, I'm HIV positive, and quite often they'll tell you exactly what they're on. A phone call to the ID unit at your local hospital should get them the medication, and they can be biked over to you. They shouldn't have a treatment interruption. Doesn't need to happen.